Good afternoon, everyone, and welcome to today's special webinar for Canadian Public Health Week on a public health approach to sex work. My name is Ian Colbert. I am CPHA's Executive Director, and while we're all joining this virtual platform from different parts of Turtle Island, I'm joining from Eastern Ontario on the unceded ancestral territory of the Algonquin and Anishinaabe. Very pleased to have you join us today to talk about this important topic. And I just want to let everyone know that today's webinar is being recorded and all registrants will be notified when the recording is available on CPHA's YouTube channel. At any moment, you can pose a question using the Q&A module. And if you'd like to introduce yourself and let us know where you're joining from, you can do so in the chat. So it is now my pleasure to introduce today's presenters, Natalie Brender, CPHA's Director of Policy, and Cecilia Benoit, researcher from the University of Victoria. And with that, I will turn the floor over to you, Natalie.
Great. Thank you, Ian, and thank all of you for joining us today. This has been a topic that's been a really important focus of CPHA's policy work over the past couple of years, and I'm really pleased that we can share some of our perspectives and findings with you today, especially in the company of Cecilia Benoit, who is one of Canada's most eminent researchers on this topic. Next slide, please. I am, yes, thanks. Next slide. I also am joining from Ottawa, which is on the ancestral and unceded territory of the Algonquin Anishinaabe people. And on behalf of Cecilia, her acknowledgement states, I am privileged to be here on the uninvited lands of the Lekwungen-speaking peoples on whose traditional territory the University of Victoria stands today. Next slide. So to give an overview of what we'll be doing and sharing with you today, I'll start by going over briefly why CPHA released a new position statement on sex work in 2024, 10 years after we had released our previous one. Then I'll discuss what we mean at CPHA by a public health approach to this topic. Then Cecilia will pose some questions to you in the audience about your current views of sex work and a public health perspective. She'll present to you her research on sex work stigma in healthcare, talk about unmet health needs and the dilemma of disclosing work identity. And then I'll come back and talk about what public health professionals can do now to put the evidence and learnings into practice. Next slide. So these two images just capture where we came from. On the left, the image is of our previous position statement released in 2014 of sex work in Canada. On the right is the cover of our brand new position statement. Next slide, please. You may ask, why did we present a new position statement just 10 years after the previous one? What led us to think this was necessary? Well, a large factor was that immediately after the publication of our previous position statement in 2014, the federal government brought in the Protection of Communities and Exploited Persons Act, which replaced a previous federal legal regime governing sex work. The new act criminalizes communication in public places where children could be found. It criminalizes anyone purchasing sex and most advertising for the sale of sexual services, as well as the use of third-party helpers to facilitate the conduct of sex work. And in the 10 years since that law has come into effect, we have seen that the impacts of that law were, as sex workers feared in 2014, very detrimental to their health and well-being. A year and a half ago or 2 years ago, sex workers and their allies brought a federal court case to, a court case to the Supreme Court of Ontario, arguing that the impacts of this law violated their charter rights to safety and security of the person. and that legal suit was dismissed in the Ontario Supreme Court. Next slide, please. I should add, actually, before I go into this slide, not only was the case dismissed in the Ontario Supreme Court, but it's very likely that there will be a federal challenge, thank you, to this law again at the federal level, which is why it is important to bring forward a public health view and evidence at this time. So, what is a public health approach to sex work? I imagine all of you will be quite familiar with the core concepts and values of public health. But in this context, it's particularly important to emphasize two, I'd say. One is anti-stigma, and you'll be hearing more from Cecilia soon about what this is in the context of sex work and how it impacts sex workers. Um, there's a larger question of why is it important to affirm these specifically in discussing these value-based starting points in discussing sex work. And it's important to say that to note the reality that there's a lot of societal resistance to the idea that health equity for sex workers should be a core concern for public policy and practice. Their work isn't only highly stigmatized in Canadian society, but it's actively opposed by other interest groups. Um, and so that's why it's very important for public health to affirm that health equity is as important for sex workers as any other population. Next slide. What are the kinds of evidence methods and approaches that we brought to our position statement? They are primarily qualitative research by academic researchers using mixed methods. Because sex workers are a difficult to reach population with great diversity, doing sex work does present some methodological challenges, and these have been extensively noted and discussed by researchers themselves. Research and evidence gathering is based very much on community consultation, building on community knowledge of what's needed to improve their health and well-being, and centering the perspectives of people with lived and living experience who know best what their needs and realities are. It also depends, of course, on intersectionality, understanding where overlapping social identities compound health inequities, and taking distinct approaches to addressing these. Um, it's important, finally, in thinking about health equity, to look at this through a lens that understands sex work as work, and that it's necessary for this kind of work to be made safe, just as for any other kind of work done by other populations. Understanding that harms for sex workers are created by social policy, law, and practice, and that these can and should be changed. And this is what it means to take a harm reduction interest in sex work, not to accept any premise that sex work is intrinsically harmful, but recognizing that societal conditions often make it so. That sex workers have reasons for doing this kind of labor, that it brings benefits to them, even under conditions that can make it harmful, and that the mandate of public health is to use evidence to change these conditions to reduce avoidable harms. Next slide. And now over to Cecilia.
Thank you very much, Natalie. I'm going to move to a poll first before I present some research. So Ian's going to present the first question, and then I'll present the results, and then we'll move on to the next one. So most sex workers are girls and young women in their teens or early 20s. Yes, no, or not sure. Yeah, so we have half people say no, 12% say yes, and then another 1/3 not sure. Well, from the research that we've done in our lab, the average age of the sale of sexual services was 24 years old, and people were in the industry for an average of 10 years. And about one quarter had started their first sale of sexual services before the age of 19. So we see that actually most people, just like other workers, are starting into sex work as they start in other service jobs when they're young adults. Next question. Most sex workers begin doing this work in the context of exploitation or trafficking. Yes, no, or not sure. So 30%, 39% say yes, a similar amount say no, and then about a quarter say not sure. So again, in our research, we asked similar kind of questions, why people, what were the conditions in their lives when they first began. And an amazing 80% said that they needed the money or they wanted the money. So the money, economic need was the primary reason for people engaged in sex work uh, at the beginning and also throughout. And that is the primary reason why we all work. We work for social reasons as well and so on, but most of us work to make a living. In our study, we found about 29% had adverse living situations when they first began. And another 25% said they actually liked doing the work, so that's why they engaged in it. So quite diverse reasons, but predominantly economic for why people engage in sex work. The next question, please. So the most pressing health needs of sex workers are related to sexual transmitted disease, drug use, and violence. Yes, no, or not sure. So the majority of you say yes, minority no, and again, around 20% not sure. And again, in our research, the most pressing health need is actually not related to sexual transmitted diseases or drug use or violence, because especially in regard to the former, sex workers are actually quite good at accessing safe sexual practices, and drug use is a concern, but only for a minority of them. Violence is a major concern, but that it is largely driven by what I think the most pressing concerns are the lack of access to social supports, economic supports, so social determinants of health, and in particular, dealing with the stigma they face in healthcare and police and other institutions. So again, thinking about the public health framework here, that we need to move back from just the kind of what the behaviors and looking at the social determinants of health. Last question, please. Public health professionals should structure service approaches around the premise that sex workers don't want to be doing sex work for a living. Yes, no, or not sure. Yes, no. So a large portion, no, and not sure. And I would agree with the no. We when we asked sex workers in our study about um, whether they want what the pros and cons of doing sex work, and we must also remember that many of them have worked or currently work in other service jobs in order to make a living. Actually, there's some positive benefits of sex work vis-a-vis the other jobs they're doing, having more control over the work, and making more money, which is a major reason. Going back to the economic point I made above, so they. I don't think public health sex workers want public health professionals to try to get them to leave what they're doing for a living, but rather they would like them to have access to non-judgmental care. So when health providers intersect with sex workers as clients or patients, then they should have access to health services just like any other Canadian. Thank you. Next slide, please. So these are kind of the answers that we've already given. So we can go on to the next slide, please. So, in order to, I think, to really think about people in sex work who are at the center of our focus today, I'm myself and my colleagues use what we would call intersectional social equity framework, which builds on the concepts that we already seen above. And sex workers, like other marginalized people in our society, face inequities early in life that could include poverty, stigmatization, which I'll be focusing on today. One third of sex workers have a disability. Housing precarity is very high among them. They haven't, many of them have not completed post-secondary education, often live in harmful physical environments. And as we already seen, they have to deal with regressive laws and policies. So social class, race, gender intersect with the among the people in sex work, and so they're more likely to be poor, more likely to be from Indigenous background or other racial minorities, and gender inequities. You know, majority are cis women or people with non-heterosexual backgrounds. But there are conditions that can decrease their risk and enhance their capabilities, giving them agency, access to rights and protections, access to social programs, including education, supportive friendships and family networks, and our focus today, which is access to non-judgmental services, whether in healthcare, police services, which I've published on a lot, or even in schools. So we have to think about it in a multi-generational kind of way and drawing on the various frameworks that are listed there. Next slide. So in the study I'm going to report on today, we've done other studies as well, but this was across a number of communities in Canada, from east to west or west to east. And we interviewed 218 sex workers in person. That's the study I'm going to refer to, but we also did study on people who purchase sex, community groups, including police and so on, who intersect with, and health providers who intersect with sex workers in the communities. We also did interviews with people who are managers of escort agencies and massage parlors and so on. And so we had and we also interviewed people who are intimate partners of sex workers, and have published on just showing that, you know, sex workers are not necessarily any different than the rest of us in relationship to need for intimacy and care in personal relationships. So a diversity in regard to backgrounds and circumstances. The results show that sex workers are marginalized on most social determinants of health, which I've mentioned, but they have higher personal income, which is one of the big reasons why they're involved in the work. Work context matters. So in different communities across Canada, sex workers seem to have more control, more ability, but even within municipalities where they deliver services and so on, the context matters. And the municipal context matters because there are also a number of laws, regulations within municipalities that govern sex work. Overall, participants report very high stigma and discrimination, and again, that's something that that I will focus on today. So, high levels of stigma and discrimination when accessing police services and health services, but once they get into the service and people are approachable and non-judgmental, then they actually return for that for health services. Next slide, please. So how do we understand stigma? Stigma is a very complex, difficult term to understand and to see how it operates. The Canadian sociologist Irving Goffman was the first to actually study it, stigma and how it works in like a community environment. And this is the stigma power process is developed by Bruce Link and Joe Failing. So basically, you know, there's a cultural designation of value in a society. So it could be disability, it could be some other condition, but in our case, it's people who sell sexual services. So it has a negative cultural conception, and it's and it you know it involves people who are labeled as a prostitute or to daily indignities. And the process works that then they become concerned about staying in, so they want to remain hidden and from others. So they develop a consciousness about the stigma, and they have various ways of concealing it. So being partially out, being not out at all, or being concealed completely about what they're doing for a living. And eventually that can lead people to be to avoid others and it can have a mental health impact in regard to lower self-esteem. So this is really important. It could be used to study lots of concerns people have with stigma in society, having to do with you know, other statuses or other behaviors. And so I think it's a very important way to try to see it as a process. Because it's a process, we can actually reverse it. We can change it. We can develop process strategies to reduce and maybe even to eliminate stigma. The next slide. So in relationship to sex work and thinking about stigma, we have to think about three intersecting kind of taints that affect sex workers. The physical, social, and moral, which I'll talk about. For other people, so for example, I've done a study on stigma with people who are legally blind. They experience, you know, physical and social taint, but not moral. They're not blamed for their disability. So it's a little bit different for sex workers. Next slide. So public health has, you know, a long history of conflating people in sex work and STIs, going back, you know, to the previous century, and people, the clients are not blamed, but the sex workers themselves are blamed for, you know, transmitting diseases and so on. So we have that that notion that sex workers are kind of conduits of disease. Next slide. We also, there's a social taint linked to sex work because they are linked to people who also are shamed in our society. So whether that be clients who purchase sex and they get called out, or people who use drugs. So there's this assumption that everybody in sex work use drugs, and therefore both of them are one and the same person. And that's the problem with a lot of studies actually on sex work, because they only interview people who use drugs and then assume that they also are sex workers. Next slide. And finally, we have a kind of a moral taint in especially it ebbs and flows in societies depending on the conservative or more liberal notions of activities people do or behaviors in society. But in the last decade or so, the public values in Canada had a very strong moral taint against people in sex work. And our former Justice Minister said most Canadians view prostitution as a dehumanizing phenomena, and that Bill C-36, which is the current PESA law, protects those who are most vulnerable by going after the perpetrators, the perverts, and those who are consuming this degrading practice. So that's pretty stark depiction of a certain moral take on the activity of selling sexual services and buying them, and it makes it very, very difficult for people in sex work then to be able to escape this kind of pervasive moral stigma that surrounds their activities. Next slide, please. So how do we then, so trying to think about stigma as something that that is a phenomena that emerges in society, and it is activated in society. So what are the sources of stigma? Where do they come from? And in this diagram, we can see that they're on a macro level, which we've already kind of hinted at, our laws, our regulations, and policies. The media can also be a major perpetrator of stigma, or its reduction. It's a good mechanism to actually reduce stigma. Today, our focus really is at the meso level, looking at our institutions and the actors. So in the healthcare system, healthcare providers, in the justice system, police, judges, and others. Those are really important for mediating stigma, whether trying to reduce it or perpetuating it. And then at the micro level, of course, everyday life, we interact with people in sex work. We also often don't know who they are, but once we do, sometimes they become called out. Children are told are in school settings, a children's mother or father could be called out in that kind of setting or other places. So in public, and also individuals, we ourselves are not free from stigmatizing others. So even though we might maybe stigmatize ourselves, we can actually do the same to others. So Goffman often talked about, any of us could possibly be stigmatized, but it's those who have the determinants of health are stacked against them are more likely to be stigmatized. So this is a useful diagram to try and understand how, and these macro, meso, and micro levels intersect. So it's a complicated way it takes place. Next slide, please. So in our study, we tried to use measures that could give us some comparative data on sex workers compared to other populations. So we used the perceived stigma scale, which was from Bruce Link and Joe Phelan, and try to understand how sex work compares to other stigmatized identities. And what the scale is telling us is what the participants feel the general public thinks about them, right? So about so in our case, sex workers' perception of the general public about what they do for a living and how they interact with others. So you can see here that sex workers have very high level of perceived stigma scores. So they really think people in society, and this can be in their personal relationships, it can be in social settings such as schools, healthcare, and the legal system. They believe that others have a high perception of stigma towards them. People with mental health conditions also have high perception of stigma. They feel called out in public and so on. Legally blind people, study I've done about my colleagues, a little bit lower, and even people who provide services to sex workers. The study was a sex worker organization where we interviewed the providers in the organization. They feel stigmatized as well. And that's usually by what we call stigma by association or courtesy stigma, where being in the presence of others who are highly stigmatized, you become stigmatized as well. So stigma is perception of stigma is quite high among sex workers in Canada. Next slide, please. So a little bit closer to the topic of today, we also asked sex workers about their unmet healthcare needs, and we found that, and then we compared them to the general population at the time we were doing the study. We found sex workers are much higher unmet healthcare needs than the general population. And even when we control for social determinants of health, Indigenous status, and other social determinants, they still have sex workers still have a very high level of unmet healthcare needs. So we really wanted, and then we wanted to get at why that might be the case. Now, the Canadian Community Health Survey only asked certain reasons or list certain reasons and didn't get around to it, didn't bother. That is common for Canadians as well. Some of us, we don't go to the doctor or to the nurse if we're lucky to get one because we weren't able to get around to it. Other reason, which is common, is too busy. So it's higher for sex workers, but we see here that is also significant for the common population. One that is very low for generally for Canadians, but was high for sex workers was dislike of doctors, and another was transportation. And I think the transportation gets at again the social determinants. Sex workers are much less likely to have a vehicle, or less likely to have access to credit. So there are various reasons why not being able to get to a health facility is higher for them than others. But I'm going to focus in on the dislike of doctors or afraid, which gets at, again, I think, at some of the fears sex workers have when they attempt to seek care in healthcare settings. Next slide, please. So in an open-ended question, we asked sex workers, have you ever accessed health services for work-related concerns? And we had, the majority had, and then when we looked at their answers, we seen that even though we didn't probe for it, one of the really big concerns about whether to tell the health provider they were a sex worker or not was just some fear of disclosure, fear of what would happen if they were to disclose their occupation. So this was an emergent theme, and we didn't probe for it, but it seemed to be of very high concern for the people we interviewed. Only about 20% had not mentioned disclosure or had not sought health care when we were asking. So disclosure was mentioned by 79% and then 21% disclosed was not clear. So among those who talked about disclosure during the healthcare setting experience, about 2/3 had disclosed or at least once, and one third had not. So we have now people going into healthcare, and wanting healthcare, but not, 1/3 of them are unwilling to talk about to the health provider um, what their occupation is. Next slide. So why they decided not to disclose? Um, One of the big reasons was the fear of judgment. So, here it's not necessarily that they had been judged, but it's the fear that they would be judged. Uh, and 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 if and if you fear that, then it's really, as we've seen in the stigma power diagram earlier, then it's very difficult for you to act, to reach out. Others said it was none of their business, so they were going to seek health care, and they didn't feel like they needed to say that they were a sex worker. And then others were worried about confidentiality concerns. So again, worried that the family doctor may tell their mom or other people who they know in their life, so that they're just worried about that this information will be kept private. So that's so these are interesting reasons why not to disclose. Next slide, please. And those who had disclosed, what were some of the costs? Well, this is in the actual healthcare setting where judgment, stigma, and inappropriate care were sometimes experienced for those who had disclosed. So feeling judged and feeling disempowered, and then also being looked down upon or called out by somebody who wasting tax dollars, that kind of thing, because they're seeking STI clinic training. And also, in some of the interviews, even though if you go into a healthcare setting and uh, and you've had good experience there for a long time, if there's a change in frontline staff or change in health provider, that experience can move back to costs, right? So you can never completely determine whether it's going to be safe. It may be safe on one account, or it may not be when you go back again. Next slide. But what the good news story is that for those many who had disclosed, there were benefits. And this is, I think, really, really important. So, non-judgment and feeling a trust in who they are, and not feeling judged, getting the health care they came for, um, or and then sometimes getting targeted care when. When you do disclose your occupation, the provider could provide you with tests that are targeted, that could be helpful for you, that you wouldn't have asked for without disclosure. And also continuity of care. If you can develop a good relationship with a provider and a clinic, then maybe you'll come back again and you'll have that continuous care, and hopefully seek it's good and it's non-judgmental all the way through. So there are lots of things that health providers can do to make it safer, to make it non-judgmental, and to become conscious, of biases. So I'll pass it over now to Natalie.
Okay, thanks, Cecilia. Next slide, please. The one after this one. Thanks. If to get to, if you're wondering what, after looking at the evidence and the research, well, what did CPHA end up saying in our position statement? As Cecilia mentioned, laws are one source of stigma and one source of harm, and so we do recommend changes to the federal laws around sex work to fully decriminalize sex work. And we do hope that our position statement might be helpful in that regard, but that is largely out of our hands. So the second category of recommendation we make, that is more in the hands of public health and this audience, concerns change to societal institutions. What can people in healthcare, social services, and policing do differently to improve outcomes for sex worker populations? Next slide. Um, what can you do individually and within your organizations? Well, what you can do can be categorized under the heading of ways to be an ally of sex workers. And advocacy organizations by sex workers have already done a great deal in recent decades to lay this out. You can look at publications that list 10 ways to be an ally for sex workers from various agencies. Um, Next slide. They already are quite detailed in terms of laying out recommendations by sex workers themselves of what they would like to see healthcare professionals do differently. In this document, for instance, this was published by an Ottawa sex work advocacy group about 10 years ago. I'll go into these in a little more detail. The next slide, please. So, what does it look like to be an ally with sex workers as a public health professional? First of all, avoid stereotypes about sex workers, understand their diversity. As Cecilia said, this means don't assuming that sex workers use drugs or have low self-esteem, want to exit the industry, or that they're poor parents. Um, Also understand that they live not just in big cities where you might expect to see outdoor sex work, but really in all kinds of communities, both visible and non-visible locations, and really in all communities across Canada. Um, Secondly, address stigma. What can be done about that? First of all, individually, we can be aware of our own values and prejudices and try to understand them and be attentive to how we use language in talking to and about sex worker clients. Um, then take a holistic view of sex worker clients um, and structure your organizations to ensure that this happens. Recognize that sex workers have physical, emotional, social, and psychological health needs, just like the rest of us, and take a global approach in addressing their concerns. Don't assume that their health concerns are going to be related to their work. Inform them in a non-judgmental way of what services are available. And of course, make sure that your organization is providing relevant services. Take measures to find out if these services need improvement. D, offer culturally sensitive services. Learn about the realities facing sex workers who belong to multiply stigmatized and disadvantaged groups, those who are Indigenous, Black, LGBTQS plus, and migrants, and ensure that the services you are offering ideally are offered by peers and that they are designed by people who understand the realities and needs of these populations. Next slide. Further on what allyship would look like in practice. Work to make your organization sex worker friendly in ways that make it clear that they are seen and welcomed as clients. This could begin, for instance, by putting up posters or signs that acknowledge and welcome them to come for services in your organization. Also, work to be aware of systemic barriers to sex workers being able to access your services comfortably and safely. Things such as hours of operation, location, and appointment policies all make a space or service welcoming or unwelcoming. Protecting confidentiality is essential, and guarding confidential information for sex workers, given how much stigma is attached to their identity and that it is in fact criminalized activity at the moment. So it's imperative to respect professional codes of conduct and ensure that practices within organizations absolutely protect these clients' privacy. Lastly, recognize sex workers' expertise and draw on them in designing and delivering your services. As Cecilia mentioned, recognize their professional expertise, that they know how to protect themselves physically and sexually in their work. But more broadly, consult and employ sex workers with compensation to help healthcare professionals know better and do better. Involving sex worker organizations in the development and delivery of education for healthcare providers and in the design and delivery of healthcare programming is essential to producing effective results. As we say at the conclusion of our new position statement, sex workers should be at the center of planning programs and services that support their health and well-being. Next slide. So thank you. That is our presentation for today. And we look forward to answering any questions you might have.
Thank you so much, Cecilia and Natalie, for a great presentation. I see we have our first question up. It's sharing some information. We do have lots of time if anyone has questions. Let's see if the second one, the IP implementing activities for key populations have included in health provider contracts a clause allowing for termination of their contract in case of reported cases of stigma or discrimination toward a patient, regardless of their sexual orientation or status. Strengthening KP and people living with HIV associations to better support victims and guide them through the process of reporting cases of stigma and gender-based violence. Equal involvement of civil society. Okay, thank you, anonymous attendee, for that comment as well. I will also point out that another one of the reasons, the part of the impetus for CPHA's new position statement is that we were contacted by a sex worker organization and saying, hey, that 2014 position statement, we liked it in 2014 and we don't like it anymore because the entire mindset and perspective around how we look at sex work has changed in a decade. And so we were really it wasn't necessarily at that time a topic that had percolated up in our priority list. And so we were really happy that we received that feedback and were able to work with sex worker organizations and did some focus tests with sex workers themselves as we developed the new position statement. And it reflects a new process that CPHA has developed regarding our policy development process, which is much more broad-based in the initial outreach, so that we are working with affected populations from the very beginning and hearing from them, and really talking to anyone who has knowledge of a topic, not just looking at the peer-reviewed scientific literature. As important as that is, it is part of the story, not the entire story. Oh, we have another question or comment. So given the sophisticated means through which criminal enterprises enter into a relationship of coercive control with sex workers, what is the role of healthcare workers, if any, in exploring and pulling apart this potential situation and exploring potential conflation between sex trafficking and voluntary sex work? What are best practices to determine if coercive controls exist? Cecilia, perhaps I'll put you on the hot seat for that one.
I think the I think the best way to do would be to consult community organizations. I know here in Victoria, I work with an organization called Peers, and they have a very good kind of liaison with the local police and so on, and they also have ways to be able to help somebody who is being coerced beyond their in the control. So I would say to be able to see for if the person feels that they are being coerced, you're working with the local sex worker organizations, and if they need access to protection and so on, then that organization will be able to help connect them to caring officers who will be able to handle this delicate situation. So the best practice, I think, would really be to work with sex worker organizations in communities. Not all of them, not every community has a sex worker organization, but they would have other shelters, other community organizations that might be quite helpful in this regard.
Excellent. Thanks, Cecilia. Another question, are there any ways that an increase in technology facilitated sex work has shifted things for better or for worse? Are there any specific recommendations or trends in better supporting folks in that world?
I think the research shows that sex workers who work online or largely have their services online are protected in many ways from some of the more face-to-face encounters that they would have with clients, especially in settings where there are not a lot of safety involved. So in a sense, they are free, probably less likely to experience physical violence. But on the other hand, there are all these other forms of violence now that are on the internet that they could be outed, and also that the governments, of course, are moving to regulate that industry, those technologies as well. So, it is increasingly difficult to make a living through online sex work because of all the controls that are taking place. And so it's a very complicated, the industry is very complicated in regard to the contexts, whether they're online or in physical spaces and communities. I really don't, I think we need more work to be done, more research, and also more work with community organizations about, what are the best strategies. Often the people who work online are quite hidden. They work alone. They don't necessarily have access to even community organizations and support. So we have to do more work on this trend that's taking place.
Excellent. Thank you again, Cecilia. I don't see any other questions at this point. So unless either of our presenters had any final words to share, I am going to thank both of them. Thank you, Cecilia. Thank you, Natalie, for an incredibly informative session today. Yes, please, Cecilia.
I just wanted to make the point that as we see with cultural safety and and training for health providers who are interacting with Indigenous clients or other marginalized populations, there have emerged training for health providers interacting with sex workers in communities. So there are modules that have been developed, and they really do kind of inform people about the diversity of the people that they're dealing with, about where some assumptions that we often make about this group, about the language, which can be quite stigmatizing, which is again analogous to what we see with people of Indigenous background. So there is ways that we can to actually train, and I would say continually train ourselves as providers with people who are different than ourselves, because we can't assume that we have it by doing one course, but just to say there are some tools out there that might be very useful. Thank you.
Excellent. Thank you for that, Cecilia. Well, with that, I will thank again our presenters, Cecilia Benoit and Natalie Brenda, for an informative session. If you want to check out the position statement, it is available off CPHA's homepage at cpha.ca. Take a look at those recommendations. And if you support this kind of work that the association does, consider becoming a member of CPHA. It's really important that we have everyone's voice part of our advocacy as we advocate for this issue and other important and social justice issues in our society, especially with a potential turn in the political climate in this country. So with that, I will wish you all a happy end to Canadian Public Health Week 2024. Thank you for being here. As mentioned at the beginning, the session has been recorded and all registrants will be advised when the recording becomes available on YouTube channel. Take care of yourselves and be kind to each other. Thank you.
Thank you. Bye-bye.
Bye.